You're listening to the She Lift Project podcast, a show dedicated to helping women achieve higher levels of success in the workplace. No matter where you are in your career, we want to help you grow. Now here's your host, Cynthia Kirkpatrick, a CPA, CFP, and Senior Financial Advisor at Moneta Group.
Welcome to another episode of the She Lift Project podcast. I'm Cynthia Kirkpatrick. Thanks for joining us today. And we have a fun guest, Dr. Rachel Feinberg. Thanks for joining us today.
Thanks. I appreciate it.
And I think we're going to learn a lot about your journey, medicine, a lot of eye-opening things. But what I thought was interesting is how we met, how you came to be here.
I was just flipping through the Clayton magazine because I get it at home. And I just saw the article and I didn't respond myself. I gave it to my secretary because I knew that she would not chicken out.
Which is so funny in my mind, for a doctor of your caliber and all the things that you've done, for you to say, giving it to somebody so you don't chicken out.
Well, you know, I'm intrinsically shy, though. All of my patients would burst out laughing if they ever heard that. And I don't know why, but I think it's kind of time to look out into the community, see what's going on, and also to not be such a recluse. I don't think it helps me. It doesn't help me intellectually, that's for sure.
And I think, you know, we have your book here too, which we'll hit upon with you and your husband. I think there's a lot of good information here that if you were just to keep it to yourself, patients and beyond wouldn't be helped by your experience and intellect.
I think if there's anything that the patients would say, they all want to be heard. There's lots of dramatic stories or the number of people that they've seen. A lot of times it's 8 or 9 people. And the biggest part about having a pain problem and not being heard is the implication is that it's all in their head. And so I have to be able in an interview to get through that quickly because I have to spend more time with the patient. And some of the things that I say is, look, if you ever drive by WashU and you look at all of the buildings, I guarantee you 80% of them are called research. So when you process that, I think the biggest mistake is that people don't say they don't know. So when you look at how huge medicine is, it never would occur to me that I would know everything. Because the discipline of surgery is totally complicated. You can't be as good in adult medicine as you are in pediatric medicine. And so it's really important to say you don't know. So physicians, when they see patients, or nurse practitioners, because they're frontline now, it's much more valuable to say, I hear what you're saying, but I just don't know what is happening. And if I find someone, I'll let you know. And so that's actually how I learned 50% of what I know. It's been 35 years now, but I always ask the patient, why do you think you have it? And so we took the route of going through the trauma history. So, you know, med will come in, you ask them if they've ever had a car accident. It's like, no. And then I'll look at the x-rays and I'll say, when did you roll a car? And it'll be, I was 18 years old and I rolled a car. And of course, if you don't break a bone, you're not going to end up in the operating room. But everything shifts. And then it's important to take that history and put it together so the person understands how they got there.
And you've had a lot of experience in different parts of medicine, but today your expertise is in kind of injury, pain management, understanding, helping people through that. Well,
some of it goes with the history, but I came out and I actually have credentials in high-risk OB anesthesia at Columbia in New York. And it's kind of challenging to practice OB anesthesia because things don't change. They're not very dynamic. And I got the opportunity to be an OR director. It was a small operating room at Incarnate, but I ran it. And we got to be very famous very quickly because we ran a tight ship. And so if I had 40 cases scheduled and we were going to start at 7:30, it was 7:30 cut time. And everybody knew that. So you learn a lot by being in the operating room theater, how a patient's positioned, how long the surgery takes, because that can affect all the mechanics later. But you have to do pre-op rounds and post-op rounds, so you're constantly teaching. And then, you're doing hospice rounds because you're in a small hospital. My husband, Barry, is the big forefront thinker, and he saw back in the late 80s that pain was going to be the future, and he was trying to get me out of the OR anyway. And some of it was I was on call every night for 5 or 6 years. And then I got someone to help. But when I broke my wrist, that's what really did it. And then we started doing the pain. And I would say within 2 weeks, I had 30 patients a day because I saw all the patients I had put to sleep before.
So you start in the East Coast in the New York area.
Right.
In the obstetrics, anesthesiology, high-risk cases, but really then saw that there wasn't a lot of change, continuous challenges, learning obstacles to figure out. And so the OR space really helped you see more, do more.
Well, I was trained in the OR. I trained at Penn. And, Penn was a 38 OR hospital. So you do all kinds of cases, including craniotomy, chest, vascular. The OB anesthesia was good just in the sense that I had an opportunity for the fellowship. And I started out in New York in private practice in OB. And then when we moved to St. Louis, after a couple of years, I just decided I wanted to go back to the regular OR because it's more diverse.
So you end up coming here, as you mentioned, your husband, you come to St. Louis because he was called in to help run an area, run a hospital.
When you start out in academics, and he was at Sinai in Manhattan, you have to learn how to lecture. And so that's an assignment they give out to all the juniors. And so at that time, more so than now, but though it still does exist, the pharmaceutical companies will promote you and send you around the country to give lectures. So Barry came out to DePaul Hospital and gave a lecture, and they had just had a major financial settlement because of an operative death. And he was a cardiac anesthesiologist, and they latched onto him. They wanted him to run the OR, and that's how we came out. It was a great decision, for sure. We were laughing because you go to the grocery store and everybody says, "Oh, have a nice day." Doesn't happen in New York.
No.
So it was different, I think I learned so much running an operating room, but it was a rough start. I got thrown out of the OR the very first day after 10 minutes.
And was that back in New York?
Oh, no, that was here.
That was here when you came here to start switching to running ORs.
I got a job as an anesthesiologist on the OR team, and I'd come and I'd interviewed for it. And so I was assigned a room in the neuro suite. So it was going to be a laminectomy, a low back operation. And medicine's very cliquey. It's very interesting, very entertaining, but it's very cliquey. And so Barry came out as the chief of anesthesia at DePaul, and way back when, Christian was the opposite hospital. So a lot of the surgeons operated at both places. And then the surgeon walked into the room, and he opened up all the doors, and he screamed as loud as he possibly could, "I will not have Dr. Feinberg's wife in my room." See, I wasn't Dr. Feinberg, I was Dr. Feinberg's wife.
Wow.
It was brutal. It was brutal. And luckily you have an OR mask, so I didn't say a word. I don't think I talked for weeks. I did not say a word. I pivoted right out. And one of the keys to my success, for sure, is I'm not afraid of asking questions. And so they had me run the OR that day, which is you have to start the cases on time. You have to staff it. You have to move things around. And at that time, Marge Dye, who was a remarkable woman, she was the head OR nurse and had run that operating room for years. So I marched myself up to her desk and I said, "How would you like me to handle this?" And she looked at me and she just smiled and she said, "Are you asking me I said, well, yeah, you've been running this OR for so many years. And she said, in my entire professional career, not one doctor has ever come up to me and asked me what I thought. And she said, I'll teach you everything I know.
Wow. So that almost goes back to when you said, don't be afraid to say, I don't know. Don't be afraid to ask questions of anyone who might be. Credentials don't matter if it was her experience and her ability and her successes where you said, I want to learn from her.
Oh, and there's a lot to know. You really have to know everybody's quirks. Surgeons have quirks. Some are fast, some are slow. You have to know all that. So it was just a catastrophic day. It was emotionally very demanding. And the end of the day, and this is another reason kind of I wanted to be heard, was there was a woman physician that came downstairs. And she started to pitch a fit. And I was like, now it's 5:00 and I'm spent. So what's interesting is in medicine and in anesthesia, there's what they call the full stomach. So that if you've eaten something and if it's not an emergency, you really can't have a general anesthetic. Well, her patient had gone to radiology and had a barium swallow. So barium is radioactive material. And I guarantee you, if you aspirate it, that's it. So the woman had had barium, and it never occurred to me that anyone would be upset about it. And she needed to have an important and urgent D&C, but you could also do it with regional anesthesia. You can do a spinal, or the appropriate thing to do is just to block the uterus and do it with anesthesia standby. And she blew a gasket and she marched herself up to the hospital administrator. I never got reported in my life to the hospital administrator twice in the same day, and never again after that. And it was just like, you got to be kidding me.
So your first day.
My first day.
Running the OR.
Right.
First surgery.
Right.
I don't want Dr. Feinberg's wife in here.
And the joke, of course, is he opened all the doors. So it didn't take but one sneeze and everybody heard it. And so everyone's going to be looking at poise. And so I think it's a really smart thing to be able to not talk at certain times. Like those things I don't think would ever happen now, because women have come a long way. But it still happens in different ways. But I the silver lining is it didn't take very long before I knew how to run an OR and run it well. And so at the end of that year, I had an opportunity to interview for the job of running the OR. And they gave it to me because I could answer all the questions.
So looking back on that first moment getting kicked out, it sounds like you wouldn't change anything.
No, I really wouldn't change anything. Perseverance is really important. It's very important. You have to be able to persevere. You can't really survive. And like everybody has a story. Everybody has a story. Like sometimes you'll just hear people complain about, not being good enough or that. And it's like, look at it. Princess Diana wasn't good enough for the Queen of England. Right? So everybody has a story. It's how you deal with your story.
So you start that day kicked out, you end that day with getting reported on. In the end, what ended up happening with that surgery?
In the end, we didn't do the case. We couldn't do the case. It didn't matter who. And then there was one other anesthesiologist working that day. He came to do the case, but he did the case with local standby also. He wasn't going to put that patient to sleep just because she was screaming. That was a non-issue. I think it was just being the new person. But even so, none of it was appropriate. I mean, think about it.
Well, and sounds like, again, at the end, you knew what you were talking about. You knew the risks. And so
there's not a leg to stand on. There aren't a lot of things in medicine that are black and white. That's black and white.
So here's a question. You go home that day. Maybe your husband asks, how was your day? Do you tell him? What happens? What are his thoughts?
Well, I remember telling him the story, and I don't think that it quite processed what really happened, because he was having his own first day, And so his hands were really full because it was like coming into the operating room of the Wild Wild West. And so he had very, very similar experiences, but it was more like just buck up and keep going. And I had just finished like my first job out, and so I understood that concept of buck up and keep going. And I also understand the concept that when you're the new person, all eyes are going to be on you, and it's going to depend on how you respond. But it was really stressful. It was. I mean, it was bad.
With either of those doctors, how did the relationships evolve over time?
It all worked out fine. It didn't take very long because I ran, we would rotate running the operating room and things like that. And your skill set does become very obvious. And so that's really ultimately what wins is that if you give good care and you're always available, it's not going to take very long for people to see that. And that's what they're going to go by. It's just that when we were training and running the operating room, we were told that the operating room was our private office. And so it was our responsibility to make sure that everybody got seen, that everything was on time, that everyone got follow-up care. And the other thing we were trained in is you will never, ever, ever have a verbal indiscretion with the surgeon in the OR because the patient could die. That was just, you did not lip off. And so that did come natural, just to behave.
How is that different? Anything that's evolved or changed for today that, or that would have been helpful then? Or, hey, you know what, that works in an OR when things are high pressure?
Well, sociologically, there's a couple of differences. One is when you're in the operating room, the patient's normally asleep. And so anything can go. Probably the most peaceful time in the operating room is when you're on call at night because it's just you and the team and you don't have a lot of interruptions or, supervisors coming in and out. The OR gives you a lot of experience in, you have to be able to observe. And so you have to have a sixth sense when something's going to happen. You don't want to be caught off guard. And the more you see and the more you're around, you can tell. And so you carry that with you the rest of your life. You can walk into a room and you can see, ooh, this person just doesn't look good. I thought it was great, great experience. And back when I started, everybody in my class was just like, what do you mean you're going to be in the OR? You're such a people person. But again, at that time, it was a great opportunity because there weren't a lot of American trained physicians in anesthesia. And so the top two programs in the country were Harvard and Penn. And so we got to go to Penn. And so now, of course, the medical climate has totally changed. Society has changed. You're certainly not going to get away with that now. But I think it helps ground you. It helps you make decisions, and it helps you think outside the box. If you don't think outside the box and take everything personally, then how are you going to get anything done?
Yeah, it goes back to, again, some of the things you said. Observe, ask a lot of questions.
Oh,
don't
for sure.
act like you know everything. Kind of anticipate for what might be coming down the way. And that comes through experience, hard work, and perseverance.
And, I did that for a long time. And Barry could see that pain was going to be the future in anesthesia. And so in the late 1980s, the first two pain fellows graduated. So there were two fellows, that's it, in the entire country in like 1988 that had graduated from Columbia. So it was really new. And he was trying to get me out of the OR, out of call. We were trying to make a shift. And it all worked out because I had the girls. And so I worked really hard during the week, but I never had night call on the weekend. So I spent all the time with them. We both did.
Right. Two girls, two
Right.
daughters in their 30s now.
Right.
So moving across the country, or at least halfway, starting new jobs, new areas of interest as a doctor, 2 daughters, a lot on your plate.
But, the other thing is about when I started to do the pain was the OR tech at Incarnate had been there for a long time, Marion. And she made an appointment to come and see me one day. And she said, well, when you get pregnant, I want to retire and I want to be the nanny. And I remember looking at her. And so I would say we've always been lucky because that's the only caretaker they ever had. And Marion was accustomed to getting up ridiculously early. And she understood routine. She understood that. And the dependability and having a schedule for the girls. So I never had to compromise with them with childcare.
Well, and lucky is an interesting word to me because I sit across from you and see all of you've accomplished in your hard work and your stories so far. And I think, lucky, or maybe, she must have liked you so much for her to want to do that. So I think you probably built a little of your own luck in how you treated her and others around.
There's no question about that. No question. But it's been the evolution of a great journey. And so there's always a silver lining, So when I shattered my wrist, I was at home. We were having guests, and it was just a freak accident. My entire body went into the air and propelled, and I broke the fall with my right wrist. So when I put my arm up, it was backwards. Ooh. And, even though I had a general surgeon, orthopedic surgeon, and a hand surgeon, they set the joint and dislocated. So I had an erector set, and I continued to work. And then when the erector set came out, I noticed I couldn't really supinate. And so they said, well, you really have to work it. So I'd try working it and working it and working it. And I'm telling you, I was really shy. And one of the orthopedists worked over at DePaul. And so I didn't want it. I wanted it low key and quiet. So I kept my appointments. I didn't ask for any favors. And then finally I asked to see my x-rays, and I put the x-rays up, and I was out in the hall, and I could see that the radius was here and the ulna was here, and they should be like that.
So they're, instead of being like aligned straight, they're side by side in the opposite direction.
I couldn't do it.
And the supination, for those who are just listening, you can't turn your wrist?
Supinate. Because the ulna, the radius was shattered, but the ulna healed at its own length. The radial head healed short. And so, when I finally went to Dr. Tom Hawk, who worked with me in the OR, and I said, okay, look at this. And so he was great to me, because what he said is, he goes, Rachel, when you shatter a bone like that and you have the x-ray, it's always 10 times worse when you go in and to operate on it, because you have little splinters everywhere. So the silver lining, if I could get you to look at it this way, is that you're just going to have a 2-stage procedure. And so in the first stage, they put it in, and the radial head healed, and the head of the radius healed really well. And then the second stage was to make the correction. So he set it up and helped me actually go to the Indiana Hand Center. And Hill Hastings III operated on it. And so what they did was they took basically a piece of bone out here. So I have the ulna, and then I have a dead space, and then I have the rest of the ulna. And they took a piece of the supinator muscle, drilled a hole, and it rotates. And I have full motion, and I don't have any arthritis at all. But the thing was, I had an external fixator with my arm overhead for 3 to 4 months.
So your shoulder, your arm, everything was like immobilized above your head.
Well, because if I carried it below, it was too much pain. So, and I was working. So the way it ended up was I had escalating hypertension, 220 over 115, and my teeth hurt and my head hurt. And so when I went to try to get treatment, I was just like all the other patients. It's like, well, how's your marriage? Or how, you're just stressed out. And I was thinking to myself, because I wasn't very verbal. I think some of it was because I didn't want to yell at anyone. But I was thinking to myself, didn't anyone go to medical school? You have baroreceptors to control that. You can't just magically do that. And so I had started doing the pain, and I took a completely different tact than anyone else. And we started with manual therapy really well before it became in vogue. We started working on people and releasing the tissue and doing myofascial release. And at the time, I was still at Incarnate Word, but they had given me a whole suite just to go in and do pain. And I got the physical therapist to come downstairs, and everybody was just like, what is she doing? What is she doing? But people got better. And so eventually we had to reposition some ribs that were rotated. We had to inject the spine. We had to have it move. And I did well, but you take that information and then you bring it to your next patient.
So that sounds insane. From one, we should come up with a really amazing story, like you were, saving something from falling on the ground and shattering. That was a family heirloom of 200. We could come up with something. But the spine and the ribs and everything you were saying there, that seems so strange. Just thinking of a fall and a wrist injury.
Even if you talk to people now when they come in, if they come in for low back pain or headaches or shoulder pain or whatever, everyone comes in with the perception of reality that it's about my neck or it's about my shoulder. And I finally look at them and I say, okay, so what you're really trying to tell me is nothing else exists about you except that shoulder. And they go, well, what do you mean? And I said, well, what's it connected to? And really, for someone to, really progress, like really go for it, you need the patient. And so someone once said to me, it was a marketing person a long time ago, and we were having the discussion, and they said, well, if you market this, you're not able to give them instant gratification. It's not like you're marketing and saying, oh, you're going to get 1 or 2 shots and everything's going to be fine. And it's like, well, it's not going to be fine. It's not going to work. It'll work short term. So it's been a process. And then, of course, I got breast cancer when I was 40. And a lot of people don't know that because it's been a long time. And I had radiation and I had chemo, and true to my nature, I had surgery on Friday and I went to work on Monday because the girls were little. And I needed them to know that I was going to be okay. But, the chemo was really rough and the radiation was really rough. And then after that passed, could really see the ribs go crazy because the ribs all rotated, because what happens is the muscle contracts. The pectoralis muscle contracts and the ribs rotate and you don't have the same range. And so then there's the whole evolution of the science of plastic surgery with chest and with breast implants. And so there aren't a lot of people in the world that do pain and rehab that broke their arm and had breast implants that do biomechanics and rehab. And so now, more recently, and I would say the last couple of years, the surgeons are really becoming alert to this. And so they're trying not to put the implants in under the muscle because it makes all the ribs cattywampus, basically. And they've designed a way to create a pocket that they put on top of the chest, and then they put the implant on that for the women that have had cancer. Wow. So it's going to save the spine.
And so the wrist injury, the cancer, again, ask the question, sounds like having those things have helped you become a better doctor.
Without a doubt.
Would you change those?
No. I realized that I would not change those. And I was born to be a doctor. And even with all of the trauma that we get from insurance carriers, which is brutal now, it's just destroyed everything for us in particular, I do not regret that career. And it was my big connection to humanity. It gives you the opportunity to have intimate relationships with people that tell you their secrets that believe you when you say it's not going to go in their medical record. I mean, I have patients that call the office and, they'll say, oh, I'm having back pain. And they really sneak in because they want to talk to me. Or sometimes I will see the children of the patients because we don't normally do pediatrics, but we'll see some teenagers. And, most of our practice is word of mouth.
So they sneak in to see you.
To talk
In that humanity.
Mm-hmm. And I think that, on the one hand, I'm sort of a recluse. What's really nice is when I go out, people don't know what I look like. And that's kind of been fun. But on the other hand, in the office, it's different. You have to give a piece of yourself. And that's how you know how. It's like I've always thought to myself, every doctor should have one bad migraine so they know what it's like. Because if they don't know what it's like, then when the person comes in and they have pain, it's like for breast cancer women, what's very interesting is they'll come in and they'll have a pain problem. So the rational thing to do is to see their oncologist first to see, have they been unlucky? Is the cancer back? And what they'll get is you ought to consider yourself lucky. And when you talk to breast cancer patients, would you really talk to them? I don't know that anyone's going to wake up in the morning and say, I am really lucky that I got this breast cancer. That doesn't happen. And so there's that piece of rage, and they do get a little rageful or resentment. And it'll say, well, you give me chemo, you give me radiation, I live a lot longer, but you're not helping me live. And I understand that. And so, just because you have breast cancer doesn't mean that your cancer is back. It can, but if it's not, you don't stop there. You do the rehab exam. And a lot of those people get better. A lot.
And I would think, as you said, you do the chemo, the surgeries, or the whatever, it's gone, that's done. But you're saying it's not.
Well, what I'm saying is from the perception of reality of their physicians. Okay, let's say the patient's complaining of back pain or shoulder pain, and they go in and they're trying to tell them how bad this pain is. So they do the right thing and they do the testing to make sure that they don't have a return of their cancer. And then when the testing comes back, the patient says to them, well, what do I do about my back or shoulder pain? And they get told, well, you ought to be grateful. And it's like, they're not grateful. They're not grateful. It's like they want a solution.
Right. You're grateful that, yes, the cancer's not there. You want help. Right. How do I deal with this?
Right.
And I don't want to be either just shoved out because it's not your area of expertise or shipped around from person to person.
And so, there's lots of different modalities in treatment. And, I obviously have a bias because after 35 years, I've seen thousands of patients.
So it will definitely, I think, pain management, it's surprising to me that still feels so new in the medical world. When you said there were 2 fellows, I think in the late 80s. But I want to go back to, you said I was born to be a doctor. Tell me about that. I'm just imagining a little you, a little Rachel, like with pigtails going, I'm going to be a doctor.
Well, I grew up in a town of 1,800 people in upstate New York, close to Niagara Falls, that area. And one of the things that the public school system had was they had a debate club. And so you'd debate, and there'd be like a couple of national debates a year. But when I sat back and thought about it, it was all about who could lie the best or who could verbally manipulate the right data. And so the thought of doing something in that venue just didn't appeal. And even though we were in a very small town, it was a very unusual town because historically it had a sulfur spring in it. And FDR went to that small town to bathe in the sulfur spring water to see if it would help cure his polio.
Wow.
And so that hospital stayed there. So, I was exposed to it. And I just wanted to be a doctor. But I think a lot of it is that it is a direct connection to humanity. It's definitely intellectually demanding, but it, at least for me and my experience, it was a full life. And for that, I'm grateful.
To your desires, it fed into your desires of intellect and challenging and knowing things and learning things.
And helping people. And the other thing too is that you learn from them. That's a big deal, to be in a career where you're seeing all of these people and you get the opportunity to learn from them.
And I think that's interesting. You know, I'm getting to my later 40s. I remember growing up that, and still, but especially back then, you know, doctors were revered. You don't ask questions. You do what they tell you because they know better. And so you've said several times things like, I learn from my patients. I would rather tell them, I hear you. I don't have the answer offhand, but we'll find that. So it seems so refreshing, not only in that regard, also with your wrist, and as we learn more for people to be an advocate for themselves in their own health journey.
They have to be an advocate. And now more so than ever.
Why do you think that is now more so than ever?
Well, it's a big loss with the insurance company, because if you think that the patient needs a procedure or they need a test, then you have to ask the insurance company permission. So very often they will have internal procedures. And so there are many insurance companies where their internal procedure is deny the first time or deny the first 2 times. And so people get exhausted, and so they can't get the right care, and you can't give them the right care. And so they have to also be their own advocate. And I coach people all the time, because people would come in and they'd start yelling at us. It's like, well, you didn't call and get this pre-certified. And I came out of the room one day and I said, wait, I'm going to teach you something today. I said, it's not my policy. It's your policy. They don't care what I think. They don't care that I'm the doctor. Okay, they're only going to care what you think. So if you're going to roll over and this is all it's going to take and they're going to save all that money, shame on you. And so they started calling. And I think that has helped. But now, like, one of the things that drives me crazy is low vitamin D is an epidemic. It is. It's an epidemic. I had a young man that was a student from Columbia University, had a motorcycle accident, and he took his femur and he shoved it all the way through the pelvis. And it's like, how can this be? Well, his vitamin D level was 12. And the normal range in vitamin D is 30 to 100. But I like to see the vitamin D level at 70. So not only does it affect bone metabolism, but it also affects pain. So it's really important for pain. And mentation, you know, and perception. It affects so many different things. Well, there are insurance companies that won't cover a vitamin D blood level. And I tell the patients, I said, it's a standard of care. You have to get a vitamin D level once a year. And they'll say, but I'm on vitamin D. And so then, you know, you tell them, bring in your vitamin D bottle, and the bottle will say 400 units. Well, I'm darkly pigmented. I'm in the garden all the time, and my vitamin D level was 29, which is too low. I really mean it about the 70. So I take 6,000 units a day, and that's what it takes. Well, you can tell that 400 units isn't going to work. So they're creating a bigger and bigger monster, because what happens is you've got the low vitamin D, and the time passes, and then you've got osteoporosis. So then you don't treat the osteoporosis, because I ask the patients, when was your last bone density? And they'll say, I've never had a bone density. And then the next thing you know is they're osteoporotic. And then they're going to slip and fall and fracture their hip. And so when people look at data, and that's what's really hard about research, when they look at data, it's skewed, because it starts with that vitamin D.
But I thought it was milk and calcium. that led to osteoporosis.
Well,
Dairy's
not so great, but that's another story for different opinions. But it has the calcium, but it doesn't necessarily have the D, and you have to have D3, and the supplement also has to have vitamin K in it. Then, as we look at life today and we look at diet today, it's no secret that obesity is probably the number one problem in America today. But the other thing is, in Europe, you cannot, in Denmark, for example, you cannot get a cookie or a French fry or a chip that has a hydrogenated fat in it, because it's well known that it causes a free radical and causes cancer. But in the United States, oh my, it almost reminds me of like, what will the neighbors think, if we created this change? And there's only so many minutes in a day, and you can make up a list and you can make recommendations to patients on what they should do and how they should change. And everything's really important. It just is.
And when you mentioned the low vitamin D, the problem comes from insurance carriers not covering
That's right.
the
The
testing.
Right.
So then people don't know how low.
Especially if I'm sending somebody to surgery, because there are definite indications for surgery and you don't want to delay it if it's necessary. I want them to go in to spine surgery with good vitamin D because they have to fuse. If they don't fuse, it creates a pain problem. So there's a lot of dynamics. And the other thing that's happened is that primary care physicians are getting slaughtered. They can hardly keep their head above the ground, and they're working with nurse practitioners. And I mean, I have two fantastic practitioners. One's a nurse practitioner and one's a PA. And if they could be my internist, I'd be real happy with that. They're really knowledgeable. But they don't cover these things. So I have this sheet of paper, we give to the patients. It's like standard of care. You need a mammogram, you need this. And then I give them a list of different vitamin companies that are reliable that you can get on Amazon. But it's hard because I have to do my job too.
So there's a lot in the medical world, and the side angles, insurance, or whichever, that make it very challenging to treat the whole person.
It does.
And to treat the whole person well.
It does.
And with pain management, I mean, it wasn't too long ago that I had done something with my neck and upper back. And usually that will fix in a few days, but it was like 2 weeks. And I was sitting there thinking, if I had to go through chronic pain, this would be awful. I would be probably so crabby and cranky. You can't sleep well.
Right.
And what a visionary to think pain management is going to be so important in the future.
But, maybe this says something about me, I don't know, but here I am at my career where I know I'm doing great work. I know I am. And I just feel this horrible vacuum, this horrible loss, because I always visualized having a practice where we would be the central square, where injury specialists would be there, where we would diagnose, because we get spine x-rays. MRIs are super important, but an x-ray tells you something different. We get spine x-rays, we look at biomechanics, we look at details, we look at all that. And then you treat them. So we use high-tech interventional medicine or injections, but we use the manual therapy also, and you mix it. But then after that, they have to go out into the world, and everyone's not going to like yoga, or everyone's not going to like Pilates. So it would have been great to have Pilates here, yoga here, strength training here, and now functional medicine, where you could talk to someone about diet and autoimmune and rational vitamins and have it all under one roof. And it didn't happen.
It sounds great. Sounds like a great plan. Why Why can't we get that to happen?
Well, back when I started, I did have a manual therapy team at that time, and we grew together. We worked together, we grew together. We had clinical rounds once a week on how the patients were doing. And then what happened, especially in the state of Missouri, they started to lobby to the Board of Healing Arts that they did not want to have physician ownership of PTs. So I'm not the type of person that's going to have a billboard, with my picture on it. That's not going to happen. And so what I did was I put my revenue into giving them the top salary in the city. I gave them continuing education, and they had 4 weeks vacation. And so that kind of squashed all the noise, or I was hoping for. But then when the lobby got more and more and more aggressive, then what my husband Barry said, and he was just fed up also, is that they could potentially, actually it was a physical therapist that complained because I guess they were having a therapy someplace else, and I pulled them out to see our manual therapist. So that therapist complained to the Board of Healing Arts that, we were just doing it for money. Well, everybody in St. Louis really knows that we are rehab, and that's really pretty common knowledge. But I lost that practice. I lost the therapist because the Board of Healing Arts voted that physicians should not own. And what Barry said was, yeah, we would be carved out of it, but we would always be at risk that someone could just come in and say that, and then, So now I have my group of therapists. They're all over the city. And I can tell who does good work and who doesn't because it depends on how the patient does. But I always give the patient a set of their x-rays because they don't fax to the therapist. And I always work on them before they go to therapy because I tell them you have to be your own advocate. And so I need you to understand that this and this and this is important. And a lot of those therapists work manually. But what is so unfair to the physical therapist, and lay people don't know this, and they really should know, is that the insurance companies, what they did, and it really started with Health South, with Scurzy, because what he did was he went to the insurance company and he said, okay, if you're going to be charged $100 for something, we'll do it for 50 cents. And so what a physical therapist gets paid, 4 years of college, physical therapy training, some of them have PhDs, is less than the massage therapist. Now, the massage therapist, there's a lot of value in that, but it's not the same level of knowledge. And so to stay in the therapy business, they're forced to see 2 or 3 patients at the same time. Or there are a group of zealots who stay and they do manual therapy. And that's pretty tragic because people will come in and say, well, they didn't spend any time with me. And I tell them, well, this is why.
And manual therapy is for those
hands-on.
So moving body parts, massaging, stretching.
Yes, all those things.
What's the alternative? That the person's doing it to themselves or it's a machine?
Yep. Heat, electrical stim, ultrasound. Okay. Heat pack, no person. Electrical stim, yes, you have a person. Ultrasound, you have a person. And then they get a series of exercises. I'm not telling you that exercises aren't important, but you got to understand this. It'll be very logical to you. If the body has a certain design, and I always allude it to a car. So let's say that your teenager takes the car out of the garage and hits the island. Well, the body of the car is perfectly fine, but the alignment's off. So then you try to drive the car across country. Well, your miles per gallon are going to go down until it puts and it stops. So what happens is you have people that are biomechanically unstable because they're having pain. They're going to therapy and they're getting strengthening exercises. And so if something is torqued or rotated, it doesn't function. And so you strengthen the torque.
And that's what I liked about your book. The pieces that I read is going back to anatomy of an injury. I should both by both you and your husband, Rachel Feinberg and Barry Feinberg. It talks a lot about how the body, everything is so interconnected. And if you're, thinking about here's my pain point, but really the injury may be somewhere else, that you need to ask questions on the whole body, not just because there's compensation.
Exactly. But the other thing too is that, when you work with a patient and you start to show them their x-rays, and then you do the exam, which is very visual. So for us, nothing's better than having a family member there because they can see the exam, whereas the patient can't. And then you do some manual releases on them, and then they start to feel. And you teach them, this side doesn't feel like that side. And you get them to see that. Then they have a better understanding. And, everybody doesn't have to go through months and months and months of rehab to be better. That doesn't have to happen. If you see, I saw a teenager a few months ago, and he had hip pain, and he got sent by his physical therapist for a hip injection. And I said, your hip's fine. And he was a lacrosse player, and it was the other side that was jammed. And so you make that correction. He did well in 3 or 4 weeks. It's making the diagnosis.
And I think sometimes it's that Band-Aid or that injection or that quick fix,
right,
versus sounds like what you guys go in and do is let's talk about everything and find the real instigation of this versus maybe that quick fix.
I think what we do is we give people choices. But also, as a physician, you have to have understanding. So let's say that someone was born with a bad scoliosis of the spine. Well, you're not going to give them a new spine, okay? But you can balance their body so they have a lot less pain. And there are some procedures that you can do that will relax the muscle for 18 months and give you a lot less pain. So you have to design a rational treatment plan within the body's ability to adapt. So probably one of the hardest patients to treat is someone with a congenital scoliosis that has a car accident. Because you have more than likely you're going to have your seatbelt on. So the seatbelt goes across the chest and across the lap. So what happens is your neck can bob, but the upper 6 levels of the thoracic spine are functionally cervical. And so if they have a congenital scoliosis, what's your endpoint? What's normal for them? You have to try, but what's going to be normal for them is you can't put them exactly in that curve that they had before. And there's 4 layers of spine muscles that go from the bottom of the skull to the tailbone. And they're all different lengths, and they attach to the ribs. So you can see it's a big thing if you have a scoliosis.
And yeah, if one's out of alignment, other places are compensating, so they're not doing their job, and it's almost kind of as you were doing with your hands there, like a torquing.
It's 3D. It's very 3D. So
what I love about this book and things that you've talked about in different spaces is really listening. So I guess maybe first I'll say, what are the challenges in pain management in medicine? Like or maybe I'll just lead into it. People think they're not listened to. People are sometimes led to believe it's all in your head.
Look at how bad that can get. Pain is a family event. So let's take the mother, okay? And let's say that she has a pain problem. Well, then suddenly the kids have a pain problem because their mother has a pain problem. So getting to soccer is going to be really hard. And the nervous system has a lot of jobs. So if you have pain, the spinal cord will send a signal up to the brain, and the brain makes chemicals, so it sends help. Well, they're still in pain, so their brain chemistry is really low. I'm not in pain, so my brain chemistry is up here. So they get a sleep disorder, and they get edgy. The other thing that pain patients will tell you is they can't concentrate, or they can't see well, or they can't hear well because they're constantly getting bombarded. So then the family unit starts to erode. And say, then the spouse, all the spouse has to hear is to go to an MD visit and have the MD imply that it's all in their head and she needs counseling. And then that just adds fuel to the fire. So it's complicated from that point of view. And even if you can't solve their pain problem, if you can validate how they feel and you can show them why they have it, because an X-ray is visual. You can see that. Or the spouse is in the room and you can show them the physical. So I think that makes a big difference. But the other thing too is that we're not all built the same. There's an entire genre of patients that are double jointed or hypermobile. And so they have certain illnesses that will affect them. So when you're hypermobile, you'll tend to stabilize with your feet. So you get really locked at the ankle. You get really locked at the hip flexor, at the diaphragm, and then at the neck. And so they, unlike other patients, will need a lot more soft tissue work because they can't stretch out their trigger point because they're hypermobile. So you have to have a certain protocol to treat that. And that's tough. But
medicine, I think, there's I don't know the right terminology words right there. There's the typical medicine world. And then there's all these offshoots where some are legitimized, some aren't, some have been, aren't anymore, will be. I mean, medicine sounds like, talking from there with the soft tissue and things, is much more than tests, blood work, some exercises, and some, pharmaceuticals or drugs.
Medicine in reality is 50% art. It is. It's an art form. A really good surgeon, for example, there are a certain percentage of people that will have an extra ligament or an extra muscle. And they'll get in there and they're operating and it's like, oh, this doesn't look the normal way. They creatively will change their procedure a little bit to compensate for that. You want to have that skill set. It's an art. If you can't listen, then you're missing the opportunity to learn something from your patient because the patient's there to tell you. If you really ask them, how long have you had this? Or why do you think you have this? And they'll tell you. They'll say, I think it's because I'm double jointed. Or I can remember being on a trampoline. Or I fell down the stairs and landed on my tailbone. They'll put it together. And that's what the physician needs. We need the patient as much as they need us. Because if the patient can't understand how they got there, and if they don't feel hope that they can get out of it, how are they going to help themselves? And it does. It makes a difference. It's super rewarding. It can be very, very rewarding. It's just hard for me now because of all the extraneous reasons.
The non-medicine specific, the extraneous, I'm thinking back to the insurance things and the other maybe, I don't know, political or organizational or business things that
all
you have
those
to deal
things.
with.
And, when they talk about the cost of medicine, the way that the insurance company does business, what they did was they decreased the reimbursement, but they increased the cost of doing business because now you have to have one or two people just to verify insurances, just to get approval, just to run the phones. Well, you figure you have someone's salary and then you have all their benefits, and that's, a chunk that goes back into it. And then if you can't do what the patient needs, then what? And of course, now in this day and age, there's also all of the pressure about medication management and the narcotics. And so it's interesting because some people will just say, we will not write for narcotics. Okay. Because you have to chart really well and you have to document well. But if you have a patient that has a crush injury, okay, Is that the right thing to do? Or maybe the right thing to do is to write for the pain medication, see them once a month, do a urine check. And yeah, it's a lot of work, but it's also part of our responsibility to do that. And that's been hard. I'm not saying that some good things didn't come from that. I think that a lot of good things did come from that because people were taking higher and higher doses because they were getting more and more pain and they were being passive. And so when the dosages started to come down, they actually started to feel better. And, you know what? I'm always trying to tell the patient, look, if you have this problem in your spine, you're periodically going to have to do something about it. And so the more proactive they get, then the better. But, you know, if you're on higher doses of narcotic, your thyroid's going to drop function. Your testosterone's going to drop. Nothing's free.
There's always a side or
Sure.
Unintentional consequence.
Right. Unintentional consequence.
Especially with medicine and how, again, it's all interconnected.
Pretty much.
So your practice sounds, you know, very successful, maybe one of a kind in many ways, or at least on the frontier early on of different ways of medicine.
Well, we're probably, one of my partners, Dr. Zhu, said this to Barry the other day. He says, Barry, don't you understand? There's nobody in the city that is the first line MD that the person sees. So usually when you're going to see a pain physician, apparently, I would know because I'm locked up, but Dr. Zhu travels some, and they'll see a nurse practitioner first before they see the physician. Most of them will not get x-rays. We also have a special posture grid that can measure the length of a leg. And that's really important because if the leg is short, the spine just completely is off. And it's accurate. And I know nobody does that. But
what are that specific, which I know you outline in the book and some of the pictures and everything, are there typical people you see, or an amazing story of someone that sticks out to you, somebody who came to you who had tried and tried and tried? And
you know, there's a lot of those stories, but here's an important one, and it was more than just one. There were a couple of teenagers. One was my patient, and he was up for a full scholarship in volleyball. So he came by word of mouth. He was having really bad trouble with his shoulder. He saw some very good orthopedic surgeons, and the surgeon said, you know, surgery's not indicated in your shoulder, go to therapy. So when I saw him, I got the spine x-rays, but I measured the length of his leg. Because you can look at someone and think their leg is off, but because the spine is so 3D, it can rotate and it can flex, extend, and then it can side bend, that you can absorb some motion in the spine and your leg can be the same length or it can look short. So I got his leg length and he was off 12 millimeters. 12 millimeters is a lot. And so what happened was that in his upper thoracic spine, the upper vertebrae, like T1, T2, T3, they're functionally shoulder. And so he rotated the ribs, it was shoulder. And so what really saved him was I did a lower injection and I put the lift in. And then we did the body work upper. And then I finished off his shoulder just by doing the trigger point injections in the muscle, and he got a scholarship and he kept it.
How have you, this may have been long ago, may not be a fair question. Do you hear from him, follow up? And
you know, at Christmas time, we get a lot of cards, and a lot of them are interesting, and we hear how people are doing. But the other one, you know, that we see all the time is if you have a peripheral joint, meaning if you get an artificial hip or an artificial knee. And it is not a reflection of having a bad operation or having a poor surgeon if the leg heals long or if the leg heals short. It's not. Because, you know, there's different technical aspects of putting in the artificial joint. But it's important that if the leg is off, it's going to affect the rest of the spine. So let's say that one leg heals long compared to the other one. every step you take with the long leg, it's jam, jam. Well, it's your SI joint that's going to get locked up. And then once the SI joint locks up, and then you start to waddle when you walk, and then over time something else will happen. So in our patient population, because that's what you have to look at, is the leg length discrepancy can be very, very frequent. And patients will say all the time, I can't believe you're going to tell me this little piece of rubber was the problem. And I'll say, yeah. You know, our second daughter is off 13 millimeters. And she would internally rotate her ankle all the time when she was walking. And right before she went to college, she was like, look at what you do for a living. You don't care about me. And I said, Tova, I've just been waiting till you were ready. And we brought her in and we got the films. She's off 13. And she has a lift in her glove compartment of her car, because if she doesn't have it, she will get a migraine headache.
Wow.
Because that's where she gets the hit. And so it's interesting. And, you know, I got a telephone call from the chief of radiology. This has happened to me twice, so it's not just him, but the chief of radiology. And he called and he was furious because one of the patients had sent a letter that said, you measured my leg length wrong, and I want you to know that it's really important. So he calls me and he's yelling. He's really annoyed. And he says, you know, where in the literature does it say that the leg length makes a difference? Well, the studies in the literature that were done were just random studies. So they weren't done on the pain population. They were just done in people. And so depending on how the person uses their body, if they're not marathon runners, you know, or they're more sedate, then you could have a leg length and not have pain. But the studies were never done on a pain population. So what happened was, you know, we had a lot of data and we did a study, and there's a very, very high incidence of shoulder dysfunction with the short leg. But then when it came time to publish the study, we couldn't publish the study because we weren't at the university and you didn't have a study number. So anyway, he's screaming at me, and I just said, thank you for your time, click. And then I got another call. This was about 3 or 4 years ago. It was brutal. Chief of radiology, and she was just hot to trot about how dare I order these arthrograms of the hip. And who do I think I am? I'm yada, yada, yada. And on she went. And so then she was challenging and saying, well, who are you working with? Well, you know, when I have certain problems, there are a couple of surgeons that I'll send to. Both of these guys were hip people. So I said, well, so-and-so. And then she kind of like backs off and keeps quiet. But the way I learned about the arthrogram was there was a patient that was a radiologist, and she had this horrible hip pain, and she had 3 MRIs of her hip, but she didn't get the dye in it, so they never saw the tear. So that's how I learned it. But it's like, is it really helpful to get screamed at? Plus, everybody could hear it through the phone. And that makes me want to just take a breath and walk home.
And it's back when you started in the OR here, you get yelled at and kicked out, and these things happen. In each of those instances, you don't react, or as you said earlier, sometimes it's time to be quiet. Just thank you for your...
You know, I think in a lot of ways, it goes back to what I said before. You know, if I have any emotional feeling about failure, I feel the failure of not getting physicians to listen or not getting them to change. You know, I do feel that grief. And, you know, my patients are like, oh, but look at all the people that you help. And of course, you know, you can't help everyone. Some people you don't click with. And that's really where you have to get your joy. But it's not impossible to learn something new. You know, I think it's important.
Along the way, both specific to your practice and what you do, some of the things I've mentally taken note of or physically, I think transcend to life and almost any industry, there's an art. Listen to clients. For me, just listen to others. Ask questions of others. Don't assume you know everything. Think outside the box. To me, seems a lot of what has helped you in your success. Even earlier, when you said you asked the individual for her input on running an OR, and no doctor had ever asked her that. What is it that any of those or other things that jump out at you as a very successful, on the frontier of so many ways to treat people, doctor, that helped you where you are today?
The answer is always going to be an outcome. If the people get better, that's your answer. If you see someone and you try something and you notice that it works, then that's your motivating factor. That's what makes you keep going. There was a time where we would have a posture grid, and we would put the patients on the posture grid and photograph them front, back, and sideways, because they wouldn't understand, or they would say they weren't getting better. And then you'd put them on the posture grid and their shoulders are lining up and they're standing up straighter. And it's just that we've lost the time and opportunity to do that. But we are an outcome-driven practice. We've always been that way as much as we can. And that's what's going to keep us going. So
try those things when things work. Understand, repeat, apply.
Here's a really good one. I have a patient now, and I've had him for a while, off and on. Some people I have for years, and I may not see them for years. He got COVID, and he was very proactive after I rehabbed him. He goes to Pilates faithfully. He couldn't get out of bed. I mean, he has post-COVID syndrome. Couldn't get out of bed. The Pilates teacher said the same thing. So he has 2 members in his family that are in medical field, and one family member, I think, is connected to the NIH or whatever, but they ran all of this research, and then there was research that said that if you inject right here in the front of the neck, which is where the stellate ganglion is, which is it's a big relay station, neural relay station, that takes away the fog of the COVID. And he told me 18 hours after that injection, up at 7, out in the garden, and it's like, so I asked Zoo to do the block. So Zoo took care of him, and then of course he comes back in and he says, well, these things aren't going to be covered by the insurance company. And it's like, all right, what do you do with that? Even though you have a great result. So it's hard. And, medicine makes progress retrospectively is what they do, is they look backwards and they see what worked or what didn't work. And it's one of the challenges. It's you have to have perseverance.
Some of those other things we talked about, asking questions, listening, thinking outside the box, and everything you said there, having a lot of perseverance has led to your success in your profession, life, success with the clients. Again, whether you're a doctor or not, I think that can lead to success in other industries.
I think you have to have perseverance in all your industries. Like with Tova, she's got her own company now. It's called Vertigreens. What's really going to make that person successful is she's going to hang in there. Doesn't hurt that she's a people magnet.
Any challenges along the way that stick out to you that you learn from?
Oh.
Or is that not even a fair question? We don't have another hour to go over those.
I would tell people that there's 2 ways of looking at things. One style is to go in like a Mack truck and hit it head on. And that can work for some people. I don't know that that particularly works for women. And I think the other style, which is really what I would advocate more than anything else, is win first. Do whatever you're doing and win. And it doesn't matter if your first win is one patient or if your first win is your first client. It's a win. And then you look at that and you take that win out and you say, if you think outside the box, look what you can do with this. And it's a certain type of style. I know it's a style difference, but, you know, women function differently. And men can get away with being aggressive, you know, and if a woman is aggressive, her style of being aggressive, she's a bitch. But, you know, there are ways of being assertive. And so if you have a product in mind, no matter what the service is that you're providing, and you say, don't you think it's more important to have an end goal that wins? You know, it's hard to be noisy when people are really noisy and nothing's happening. And also, I think women have a sense of organization. There's no question. I mean, I task complete. My husband laughs because he calls me the ant, which means that I can carry like 10 times my weight on my back. And it's like, well, that's kind of what it takes. It's like, because Barry thinks everything takes 15 minutes. Even if it's moving an entire office, he's positive it's going to be 15 minutes. You know, like this year, I looked around the office and we had to clean it up. It had to get renovated. And it's like the company that manages us is a great company, you know, the building manager, but they weren't going to get to it maybe until the next calendar year. And I was like, you got to be kidding me. And so, yeah, Saturday night came. I cleaned out the storage room. You know, I got all the stuff picked up. I got it out of there. I didn't paint. I hate to paint, but we got it cleaned up and it's done. And it was a lot more than 15 minutes, but yes, it made a huge difference.
I'm sitting here for people who can't listen or hear that I'm laughing because I too may run into that sometimes with my partner in life. He brings his own great skill sets to the table. But you mentioned there, going back to the success, like get a proven track record, take action, show success, and build confidence and speak off of that.
When I got to the operating room at Incarnate Word, it was really a joke because the anesthesiologist that I worked with had a brother who worked at Incarnate who was a surgeon. So by the time I got there, the doctors were all in the doctor's lounge. This is just like the Wild Wild West. And they said, it's going to be our job to make sure she doesn't last longer than a week. And so it was the same thing. What saved me was the nursing staff was outstanding. They were amazing. But I did not talk. And I understand how to do a budget. I understand the politics of a budget. So if you're going to start 4 cases at the same time, and one of them's going to be a brain operation, and the other one's an operation on the aorta, you have to put a lot of lines into the artery and the veins. You got to get everything ready. And so the transporter was arriving at work at 7. Well, we have 7:30 cut time. So the way I started was simple. I went and I picked up all the patients and I brought them down to the recovery room and I got them all ready. And so the day came and the surgeon's running through and he's 15 minutes early and I'm sweating bullets and I'm sitting in the recovery room kind of like this. I look at the clock and he's like, wah, 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 wah. I said, you're late. It took such self-control to say that. I said, you're late. And he was like, and we went into the back and the patient went right to sleep and the patient did well. And it's like, that's your product. That's your success right there. It was really tough. They were exhausting, you know, and this particular doctor his patients would never go to the intensive care unit because he was such a wonderful doctor that if he had a carotid artery, miraculously, you know, his patients didn't go to the unit. Well, of course they have to go to the unit. So I was smart. That doesn't hurt to be smart. I took the chart and I handed it to him because the patient has to be discharged out of the recovery room to go to the next place. And I said, Dr. So-and-so, I realize how important it is that your patient not go to the unit. Here's the chart. Why don't you discharge them to where you want them to go? And then it was like, oh, just take care of it. I said, no worries. But see, I was smart. I didn't have to get in his face and tell him what a jerk he was. That has no value whatsoever. And it's like I said, okay, I'll take care of it. I sent him right to the unit, and that was it. They all went to the unit. But the guy that was there before me, it was just fireworks all the time, fireworks all the time. And that's not what anyone needs. It really isn't. It's not what anyone needs. You have to be able to produce something. And I don't know. I just think everything's important.
It goes back to, it's about the outcome. It's about the win in the end, the patient or whoever getting what they need. And so in those instances, seeing that if I come as the Mack truck, we're going to be at a standstill forever.
Yeah.
In these instances, let's pivot, let's adapt, let's be smart and adjust.
I had this conversation once a long, long time ago, and I was thinking to myself, I never said it out loud, oh my God, if Gloria Steinem was here and she could see this approach, ooh, I wouldn't pass inspection. But it was a different era. It's what it takes.
And I think you need to know who you are, what works for you. Don't try to be somebody else.
No question.
It won't work.
No question.
And know when you need to adapt. And, sometimes going into a situation to prove that you're right is more harmful.
Yeah, but the other thing that I really think makes a difference, nobody said you have to get it right the first time. Nobody said that. And so as I was going through that OR experience, I was definitely dealing with a lot of aggressive people. And I would say to myself, I should say this or I should say that. And I couldn't get the words out. So what if it took me 2 weeks, I said. The commitment I made to myself was eventually I would get the word out. And so the day would come, it'd be 2 weeks later, whatever. And I'd say, I want to get back to you on something. 2 weeks ago, you said such and such. And you were so far out of line and you were so rude, I wasn't going to lower myself to talk to you then. But I do want to let you know now, don't ever do it again. Mm. And those are strong words, but they can't get you. What are they going to get you on? That you told the truth? You do have to have a fair amount of elasticity, and you got to have thick skin. You do. You have to have thick skin.
So thinking about those who need help, need someone to work with through pain or whatever it is, what's the tip of, is it anybody with pain, anybody who can't find answers? We see anybody. We see people by word of mouth, which is probably one of our greatest strengths because that means that, it was another patient. I have a teenage boy who drives down 2.5 hours to see me once a week. And his mom said that she talked to so-and-so. And, that has a lot of value because they're coming with trust, But we see a lot of different types of patients, headaches, teeth pain, ear pain, any type of joint. So pain, injury, you have or you haven't seen somebody already and you're not getting answers and you feel like you're crazy, both things. You can pick up a copy of The Anatomy of an Injury, learn a lot, because I did, and I'm not a doctor, or reach out and contact the group.
Just come in for a consult.
And where is it that they best find you or find?
I know we're on, we're listed in the net, but we happen to be in Frontenac, close to all the highway access. So we're technically across the street from Saks.
So you can go online, look for injury specialists or the doctors at the practice, to Dr. Feinberg's, last name Feinberg, and your partner, Dr. Zhu.
Right.
Again, look for injury specialists. They're out there. If you or somebody you know needs help, or put it in the back of your mind for maybe something in the future, pain, injuries. And I just want to say again, I love that, as you mentioned earlier, sometimes you're shy or recluse, but this learning and this story doesn't come about without Clayton or there was St. Charles, different city lifestyle, really, magazine. And Kelly Lamb, I was fortunate enough to have her on the podcast, and she did a little write-up about the podcast and what we're trying to do to help people, help stories, help learning, wisdom, women, etc. And here's the little, I'm sure we'll put a better video up or a picture up, but that you and your partner, your assistant, reached out to say, hey, let's talk, let's have a story. So put yourself out there and think in different ways, and you never know what will come of it.
Thank you very much. I
really appreciate you trusting us to come on, share your story, share so much good information, and really what you're doing for so many patients out there is helping them get the answers and the lifestyle that they want and deserve. So thank you.
You're welcome. Thank you for having me. Appreciate it.
This concludes another episode of the She Lift Project podcast. To hear more episodes of the show, subscribe wherever you get your podcasts. And to learn more about our mission of helping women reach higher levels of success, visit sheliftproject.com and sign up to receive the latest news, ebooks, videos, and more.